We're here with Dr. Tasse. Good afternoon, Dr. Tasse.
Good afternoon, Tom.
Thanks for taking a few minutes out of your busy day, so we sure appreciate it. First off, can you take a minute or so to let our fibrolamellar community know a little bit about your background?
Absolutely. My name's Jordan Tasse. I was born and raised in Cleveland, Ohio. Moved to Chicago in 2003 for medical school. I went to Chicago Medical School. Subsequently, I did my radiology training at Loyola University Medical Center in Chicago, and then finished my vascular and interventional radiology fellowship at Rush Medical Center, where we are right now. Completed my training in 2013. My practice is focused primarily on interventional oncology. My research interests and such are also, I'm the director of interventional oncology at Rush, and I'm also the program director for the interventional radiology residency program here at Rush.
Wow, so that just keeps you just a little busy.
Just a little.
Yeah.
Yeah, occasionally, yeah.
Can you, since beginning to treat fibrolamellar patients using various forms of interventional radiology, what has been your overall impression of its effectiveness in treating the disease?
I think interventional radiology certainly has a strong place in the treatment of all types of cancers, including fibrolamellar HCC. It's a very new field. Many patients may not know what it is because it's a very technology-driven, minimally invasive field where we use imaging guidance such as CT, ultrasound, or X-ray to do surgeries that only really require a pinprick, where the patient after the surgery has the equivalent to a Band-Aid over their skin. And so in the fibrolamellar setting, we've treated a good number of patients, and the effectiveness has been, very strong. Anywhere from doing percutaneous ablation, in the liver, in the abdomen, in the lung, where we stick a small probe under CT guidance into the tumor, and we either heat it or freeze it to effectively treat the tumor, not necessitating the need for surgical resection, or in other patients who may not be surgical candidates due to the volume of tumor that they have, we can do therapies such as arterial chemo embolization or radioembolization, where we go through a small pinprick in their groin and we thread a catheter up through the artery to where the tumor is in the liver, and then we inject very localized chemotherapy or radiation at the tumor. We can either do that primarily to treat the tumor or to shrink the tumor to allow the patient who may not have been before become a surgical candidate for resection of that tumor due to tumor shrinkage.
Is that what the patients would refer to as the Y90? When
Correct. Yeah, that's...
So when they're asking about Y90, that would be one of those areas that you just discussed.
Exactly. Yeah, Y90 is yttrium-90. It's a radioactive isotope that we inject. When I say radioembolization, that's the same thing as Y90. And really what it is you're just threading a catheter directly up to where the tumor is inside the patient's body, just through a small groin incision, and then injecting very high doses of radiation directly at the tumor. As opposed to doing it from the outside in, you can get much higher doses of radiation to the tumor. Great.
So that brings me kind of to it's a nice lead into the next part. And I know this might be difficult to put in layman's terms, but I think it's important because you do this, and it's the double embolization procedure.
Right.
And I don't know how widespread that is, but I know that you've been using it for some of our fibrolamellar patients. Can you take just a minute or two and kind of get into a little bit of that? You could probably write a book on it, I realize, but
yes.
But to just give a rough overview.
I'll do my best, and that's another great question. That's a different category of procedure than what I had previously discussed, and really what it is again trying to take patients that aren't candidates for resection of the tumor to become surgical candidates. And one potential scenario is when there's tumor in one part of the liver. If you took out that part of the liver with the tumor, if they don't have enough leftover liver, what we would call the liver remnant to support the liver function, what we can do is go in through the portal vein and the hepatic vein, and we close off those blood vessels minimally invasively on the bad side where the tumor is, and we found that it rapidly increases the growth of the other side. So generally at 2 to 4 weeks, those patients now have enough liver, normal liver that has grown, and so now they can have the bad part of the liver where the tumor is taken out. The older scenario would be a very similar procedure called portal vein embolization only, or single embolization. And that's been done for years, maybe 10 to 20 years in the interventional radiology field. And it's the same mindset to try to grow the normal liver to allow enough leftover liver after resection to support the liver function of the patient. The double embolization is a newer technique that has just been around for now a couple years. It started over in Europe, and then it's become, being done more and more in the United States. We've done one of the larger number of case volumes in North America at Rush. And instead of just doing that single embolization, you do two separate veins. Mm-hmm. And we found that the growth of the normal liver has markedly increased. Where in the past we would expect 30 to 50% liver growth at 4 to 6 weeks. Now we're seeing greater than 50% liver growth at 2 weeks. So it's great for the patient. It shortens the time before surgery so that they can get the tumor taken out sooner. And outcomes have been great, and we've been shown that it's just as safe as the older procedure.
That's wonderful.
Yeah.
Is that something that you'd say is pretty exclusive to Rush, or is that something, that double, is that something that's done multiple places, or is that something you guys really are proud of here at Rush?
We're certainly proud, and we're part of a multi-center trial with centers in Europe as well as the United States. There are places in the United States doing it as well. Okay. It's such a new therapy that it's taking some time to be taken on, and the data is still coming out on the outcomes of it. But it is being done at a handful of centers in the United States, but to my knowledge, we've done as many cases as anybody.
Fantastic.
Yeah.
Do you evaluate fibrolamellar patients during your biweekly fibrolamellar tumor board meetings for the possible benefits using one of your procedures?
Yeah, absolutely. I mean, we go over our entire list of fibrolamellar patients every 2 weeks. And I think one of the most important parts coming from a multidisciplinary meeting like that is you have all the potential physicians that would be treating patients involved, and so all treatment options are discussed. And interventional radiology treatment options, well, be it a tumor ablation or an arterial therapy or a double embolization, as you had alluded to, are certainly discussed, and all the options are considered. And I think that's really important for patients to know really what are their options out there. Interventional radiology is such a new field that not a lot of people know really what it is. And so it's important for us to educate patients on what their available options are. And our treatments are certainly something that's considered on every patient.
Yeah, I'm not aware if you are aware of this, but you've treated, we've crossed the 50 mark now. So Rush has now seen and been involved with over 50 fibrolamellar patients just in the last couple of years. So it's made an amazing difference, and I think the tumor board has really helped bring the group together to really discuss some of the best practices and how to approach things.
Yeah, and it's an honor. I mean, we've seen just such a large number of patients in this rare cancer, and it's just an honor to us. We just want to do anything we can to kind of help treat these fibrolamellar patients. So
that's awesome.
Yeah.
So needless to say then, you recommend that fibrolamellar patients, even those that, let's say, can't make the journey to Rush, you would definitely recommend that they pursue some form of interventional radiology with their local groups or what have you. And it also sounds, Dr. Tasse, that you're willing to really reach out and even work with some of these other places.
Absolutely. Yeah, my goal is obviously to get the right treatments available and patients know what their treatments options are. And so I would highly suggest that patients just know if there are any minimally invasive options available and where they fall into the algorithm of care that would be best for that patient. And if they're not able to make the trip to Rush, I certainly have contacts throughout all regions of the United States at larger medical centers, and I'm more than happy to kind of put them in contact with an interventional radiologist closer to home that may be able to kind of do some of the minimally invasive therapies that we can offer.
Awesome. That is really great. Last couple things. Do you have plans to maybe publish a paper so that worldwide, I know so many physicians throughout the world really they always say, well, is there a paper on this particular treatment, or is there something that you can send me to that I can review or do something so that they would take, let's say, the double embolization or one of these other great, like a cryoablation type procedure. Is there something maybe in the works or plan down the road that you want to publish a paper for these fibrolamellar patients?
Yeah, absolutely. I mean, research is critical and publications are critical, you know, and fibrolamellar is such a rare cancer that the amount of data out there and the treatment options available, especially with newer emerging therapies such as interventional radiologic treatments, is just limited and the data is sparse. And so, as I mentioned, we are part of, you know, actually, I'm the principal investigator. Dr. Tasse is the international principal investigator for the double embolization procedure study that's going on at multiple centers. And so we're currently enrolling patients into that study. But additionally, we are currently compiling our data on the percutaneous ablations that we've done in the lung and the liver. And we definitely will be publishing our outcomes within at least probably the next couple months.
Oh, that's wonderful. So that's soon. That's really, really great to hear. And I know that Rush has really been involved with fibrolamellar for about 3 years now. And I think the momentum that has built just within the last year has been really fantastic. So, you know, we appreciate it very much. Is there anything else that you'd like to mention or say to our fibrolamellar community that might be pertinent to this disease?
You know, I hope that our team here and other institutions can kind of compile these multidisciplinary teams to talk about patients, and hopefully we add some comfort that we are working extremely hard to kind of find the right therapies and do the research and do what's necessary to kind of find what works for this difficult disease.
That's great.
Yeah. It's just really important for patients to know what options are available to them. You know, no matter what institution that they go to, interventional radiology versus surgery versus, you know, systemic therapy options. We've noticed over the last several years that the FibroFighters have been just an amazing advocacy group, and it takes this very rare cancer that seems like you are the only person that, you know, you may know that has it, and it brings everybody together and also gives them kind of different institutions that have offerings and treatment options available. And I just, you know, it's been amazing to see what the FibroFighters have done, you know, for the fibrolamellar community.
That's great. Well, I want to thank you for sharing your vast knowledge with us today, Dr. Tasse. I hope the information you shared will help promote the use and the potential effectiveness of interventional radiology procedures for many of our fibrolamellar patients. And we sure appreciate your time.
Well, thank you, Tom.
Wonderful.